Yep.
Yes, yes.
Thank you very much.
Thank you. Next,
Richard, it's yours, right?
Thanks, Jim, and congratulations on an outstanding meeting and what a epic ski day yesterday, and it'll be the same today, I'm sure. A couple days ago, Jim showed a video that Spencer King had put out, and it showed an early meeting with Andreas Grenzig and in Zurich, and at that time they were showing sausages. And I'm going to talk to you about a technique and a device that I definitely have conflicts on, and I'm a founder of this company called the PQ Bypass. This is a device that's not FDA cleared, but it will be soon CE mark approved, and the reason I'm going to show the technique a little bit is because physicians will be able to do this hopefully by the end of this year in Europe and soon in a trial in the United States. If you look at long complex SFA occlusions, let's just concentrate on the yellow curve, which is type D lesions. If you look at them over a span of a year, only 30% of those will be patent. If we look at these long occlusions, and these are not lesions that are in any trials, endovascular trials, simply because the vessel is completely occluded. And the question is, rather than work on the vessel, why don't you just bypass around it? Here's an example of a case Jim Joy did. This is 5-year follow-up using off-the-shelf technique and using a commercially available covered stent. That's basically the concept, the proof of concept. Jim was working on this and had been working on this for 10 years. In fact, we have 10-year follow-up on these patients. In about 20 subjects, primary patency was 82%, secondary patency was 91%, and the lesion length is 31 centimeters. Again, these are not cases in any endovascular trials. Task D in 88%, and many of these patients had Rutherford 5 with tissue loss type lesions. So at the same time Jim was doing these cases off the shelf, I was doing some animal work, writing some IP, and we combined to start a company called PQ Bypass. And it's designed to achieve the same results as bypass using the femoral vein as a conduit. The equipment we utilize is a proprietary stent graft that we've developed, PTFE, very high radial force, not like a Gore graft. We had to use, Jim had to use self-expanding stents at the anastomosis because you really need radial support. And the scaffold device or snare in the middle allows us something to aim at, and then the spring-loaded guide wire support and delivery system, a much longer wire in terms of get access, creating the initial AV fistula. The patients that are eligible, about 30 centimeter long occlusion. We want to have a proximal SFA stump, but you can actually make that SFA stump if it's really flush occluded, and then recanalization at this time in the trial, 3 centimeters above the patella. And again, it's designed to get the same results with a modular stent graft. So we report the first results of the detour technique that we're calling to evaluate SFA occlusions greater than 25 centimeters. Now, this was presented very adroitly by Gregorio Helena at Link this a couple months ago, and it included many high volume and really skillful operators. One of the presentations Dr. Helena did was 10 steps to detour. I'm going to go over this that they did in their center in Gdansk, Poland. So again, as we talked about, a modular device using these devices. So the first procedure is we go and do a tibial venogram. So we get in the tibial vein, something again, those of us that do peripheral, we use ultrasound all the time to get access. And then what we do is, let's go on to the next one if we could. And then we do a cine femoral angiogram using contralateral approach. It's 8 French right now, soon to be 7 French. And then we do a proximal PTA of the SFA, again, to get that one little site to be open enough. Let's go on to the next. And then we go from the tibial vein, go up with that PQ snare, and then we get access from the proximal normal artery to hit that snare. And when we get the snare, we go ahead and capture it and then pull it down. So once we pull it down, and you can see the access artery into the vein, and then capture it with that snare. Let's go on to the next one. And then the next. Okay. And now we have to go, and then we balloon the anastomotic site just to make sure that's always going to be resistant, so you want to make sure you balloon that site. Go on to the next one. And then after we've done that, we go with that's in the venous side, we're going down with a catheter, and now we want to get from vein back to artery. Again, what's nice about this, you're working with normal artery, normal vein, and you don't ever work into this diseased vessel. Once we get access, then we go ahead and inflate the PQ snare again to get apposition to the artery, and then we go from the vein back into the artery. Let's go on to the next one. We can go on to the next. There we go. Once we've gotten that, then we remove the PQ device and the snare. And now that we've, again, achieved AV fistula above, AV fistula below, we go distally to make sure we're all the way into that artery. And then we remove the crossing device. We make sure, again, you dilate at the anastomosis. That's always a resistant area. Again, making sure that we're getting adequate flow into the distal vessel. And then we exchange for an 035 supercore guide wire, and in this case we use our stent graft, which we call the thurs stent graft, and it doesn't show really well here as we're deploying it, but in the second segment, go on to that. There we go. So we're down with an 035 wire, and if you go to the right, then we deploy the stent graft. Again, it doesn't look really radio opaque there, but. And then we go ahead and dilate everything, and this is the proximal portion of the anastomosis, which we've got to buff up a little bit, and go to the next. And the proximal stent graft placement. And let's run those videos if they'll go. And that's just showing the post-dilation here. Let's go to the next series of videos. And now you can see the proximal portion of that bypass. And the distal portion of the bypass. And again, this is like a FemPop bypass. Now, these procedures in the hands of the group in Poland, and the first time it's going to take a little bit longer, but now these procedures are getting down to 35 minutes or less, skin to skin. And again, these patients can go home the same day, or if necessary, stay in overnight. A whole lot different than FemPop bypass, particularly because these patients all have multiple risk factors, and those are decidedly a problem. So we also do a venogram, both proximally and distally, and as you see, the veins are still patent. We're not occluding the veins. We're not opposed to the wall of the vein. And that is funny, because when we show this to sites, they first ask the question, what's going on with the vein? So in Jim's experience, there were no DVTs. In our experience in these trials, now we've treated over 100 patients, no clinical DVTs at 30 days. The femoral veins we want to use are got to be greater than 10 millimeters, most are, or at least 50% of their volume will be remaining patent, and duplicate veins are occupied, and we have not seen an impact on venous health. So the Detour 1 trial was 60 patients, 7 international sites, the usual sort of primary endpoints and secondary endpoints. In addition, we looked at venous health. So 30-day, 6-month patency, as well as deep vein thrombosis. If you look at the sites, the groups in Italy, Chile, Dr. Holder in New Zealand, and the group in Poland, Latvia, and of course Dirk and Andreas in Leipzig. Again, same sort of long lesions. We didn't care if they had only one vessel runoff, and we want to make sure that the veins are adequate. We did not get a lot that ruled out because of problems with smallness of the veins. The usual demographics, a lot of them had previous intervention, and importantly, these were patients with very, very long occlusions, 28 centimeters, again, all 93% task D lesions. Calcification at the landing site, we didn't really care about that. Almost 100% were total occlusions. So technical success was 98%. These are sites, these are their first cases, these are not multiple cases. Procedural success, 97%. Clinical success, 95%. If you look at what happened in terms of the safety and efficacy endpoints, 85% primary patency. I would have mentioned that in the few that had restenosis, 100% secondary patency. In terms of complications, we looked at everything. We had some acute limb ischemia, stent thrombosis. Some of the patients inadvertently were not treated with antiplatelet agents, but basically the numbers were certainly acceptable. Again, there's no endovascular series in patients like this, so it's hard to know how to compare this. I mentioned this fact that the veins, and this needs to be emphasized, the stent graft is not bigger than the vein, or is it the same size of the vein. If we have really small veins, you really shouldn't be doing this procedure. I like to show this Mickey Mouse shot. Basically, it's a vein, and you can see the stent graft working in it, and basically it's not occluding. So duplicate veins, no problems. We can use the stent graft. If you have duplicate vein, works out really well, and these are the flow characteristics at the anastomosis. This is one patient that had an in-stent restenosis. Basically, we need to get flush into that common femoral artery, really up close and personal to the deep femoral artery, and then you get a good result. We probably didn't, and that's why this could have been easily prevented. But it was no big problem. I'm not going to go in the venous function, but basically there were no venous abnormalities following the procedure in any of these patients. If you look at the patient's improvement of greater than 1 Rutherford class, 94% of those were achieved. So the baseline is shown. This is what they were in 6 months. Most of them were 0 or 1 following the procedure and did much, much better. So in conclusion, primary patency 85% at 6 months with almost 30 centimeter tasked D lesions. Primary performance endpoint met, no problem with the venous health. A high procedural and technical success rate. Again, all these sites, these are the first cases they did. Clinical performance in CTOs demonstrates perhaps this potential for complex patients without a durable endovascular option. And we hope that this will be an important step forward in the treatment of long SFA occlusions. Thank you very much. Any questions?
I have some comments.
Yeah.
We've been following this now for 10 years with you at this meeting.
Yes.
And first of all, congratulations. You certainly followed one of the principles that were espoused on Monday night, which was never give up.
That's right.
But it's really nice to see how this is going. The question I have is actually for Klaus. I don't know if he's still here. He worked in the beginning, he worked with you on applying this to the coronary arteries with not much success. But 10 years down the road, our stents are better. They're easier to get into places. We have a lot of tools we didn't have before. Do you think it's possible to re-explore the coronary possibilities here?
Well, I think it's possible. I'd be interested in see what Klaus had to say, but the problem with that technique was primarily in the LAD, so you couldn't treat the rights, and certainly the LAD, we want to have a successful patency, and you've got to compete with the IMA, but a stent graft occlusion would be fatal. I would be afraid of in really complicated disease, but it's certainly possible. Certainly there are a lot better stent grafts now, much lower profile, and combined with drug-eluting technology, it might be feasible. But again, I don't know if Klaus is here.
I think he's skiing.
Well, the thing that's been fun about this technology is that most of the time when you show something to a new site of investigators, all we have is animal data, all we have is theoretical stuff. But what was great with Jim using off-the-shelf stuff, and these were procedures taking 5 or 6 hours. These were not simple procedures, and that's why we put together our toolkit. But at least we knew that no problems with the veins. What's really nice about this is I think the interventionists, once they get their hands on this, they'll take those really difficult cases. It's not going to take any cases for a way that could be easily treated with a supera stent or a focal area of stenosis or even a long area of stenosis. But when these patients have failed or when they come in with disease that we all know, yes, we can work on it, but we'll be back a month later and it'll be multiple times. But they're too high risk for surgery that we can do a one-time procedure. And what's nice is you stay in normal artery, normal vein, back into normal artery, and just cover it with a really nice, very robust stent graft that also will be available as a standalone stent graft when this gets CE mark approval.
So the last question is, since we've given you so much airtime in the last 10 years, you'll give us some stock in the company?
Absolutely. Consider it done, Jim.
Thanks, everybody, for a nice morning. I think that it's time to go skiing. If you
Dr. Vogel going his talk this morning?
He gave it last night.
He did it last night. Fantastic. I'm looking forward to getting back on the slopes. Thanks, Jim.
Okay, we start at 3:30 this afternoon. Thank you.